All right. Well, here we are with the second part of the pediatric chapter. And we're going to get into some specific pathophysiology, assessment, and management of different types of diseases that cause both respiratory compromise as well as circulatory compromise. From a respiratory standpoint, just like in PALS, we're going to look at Croup, Epiglottis, Bacterial tracheitis, lower airway disease, asthma, bronchiolitis, and pneumonia. We know that a child is in respiratory distress because we can see it. We can see the increased work of breathing. During increased work of breathing, if they are breathing adequately at a faster rate, then CO2 levels will decrease. But if they're breathing at a increased work of breathing and it's not adequate, it's shallow or slow, then the CO2 levels will increase, and we know that that leads to respiratory acidosis and eventually metabolic acidosis, which can lead to cardiac arrest. Some signs and symptoms of respiratory distress in children would include irritability, anxiety, and restlessness, one of the earlier signs and symptoms in anyone who's having trouble oxygenating. You might hear some noises like stridor, which is an inspiratory noise, grunting, which is a child's way of providing PEEP, gurgling if there's fluid in the back of the throat. You may hear audible wheezing. You may see the intercostal retractions. The respiratory rate may be faster for their age. And that requires, just having an idea of what normal respiratory rates are in children. They do breathe faster than we do. As an example, it certainly wouldn't be uncommon to have an infant with a respiratory rate of 40 or 50. Are they breathing deeply as well as fast? Do you see anything like seesaw respirations, which would indicate they're working that diaphragm really, really hard? Nasal flaring, a very early indicator, accessory muscle use in the neck. It might be normal for them to have acrocyanosis around the limbs in a cold room or those sort of things, but when they have central cyanosis, that goes away when you give them some oxygen, then you know that cyanosis was telling you they were in respiratory distress. With respiratory compromise, blood oxygenation and ventilation are inadequate to meet the metabolic demand of the body. And again, in children, remember that their arrests are almost always related to this issue where blood oxygenation and ventilation are inadequate. It's some sort of respiratory problem. So a respiratory compromise is the most common cause of pediatric arrest. And it is preceded by respiratory distress, respiratory failure, and then cardiopulmonary arrest. Respiratory failure is when they are no longer able to compensate. The compensatory mechanisms of breathing deeper and faster and using their accessory muscles can no longer compensate, and they're not able to get enough oxygen into their tissue to meet their body's demands. And of course, the first organ to show dysfunction is going to be the brain. So signs and symptoms are going to be altered mental status, normal decreased muscle tone, central cyanosis, even if you do give them oxygen, decreased level of consciousness, inadequate respiratory rate, effort, chest excursion, tachypnea. Bradycardia is a very good sign of hypoxia in children, and then agonal breathing. When we have a child in respiratory failure, we need to be really aggressive. We need to open the airway, suction any secretions, assist ventilations if necessary to correct the hypoxia, administer high flow 100% oxygen, and hook them up to a cardiac monitor to see if they're bradycardic. In the absence of breathing, you're going to know they're not breathing because when you look, listen, and feel, they're unresponsive. They're modeling or have peripheral and central cyanosis. Their chest wall is not moving up and down. They are not breathing. They may have a pulse for quite some time, even though they quit breathing, because the heart is so, the heart is so strong in children. And their bradycardia will result from the hypoxia and eventually deteriorate into asystole. And again, limp muscle tone. For respiratory arrest, we are going to open their airway, suction any secretions, position them as we'll see in PALS, ventilate with a bag mask with 100% oxygen, endotracheal tube or a King or some other sort of supraglottic airway device, decompress the stomach, decompress the chest if there's a presence of a pneumothorax, cricothyrotomy is a last resort if you cannot ventilate them, and then ECG monitoring. Foreign body airway obstruction, we know from basic life support, could be anything that the child puts in their mouth and gets lodged in the back of their throat. As far as a history, you're going to get a history of a sudden onset of not being able to breathe, and they may have been playing or eating a particular food or playing around toys when it did happen. Your physical exam would be an anxious, if not unresponsive child with no signs of breathing. Therapeutic interventions, you know how to relieve foreign body airway obstruction. It's abdominal thrusts in children, and it's back blows and chest thrusts in infants, along with CPR if they do become limp and unresponsive. Definition and description. Children less than 5 are more vulnerable to a foreign body airway obstruction. Again, in that history, you're going to have a sudden onset of respiratory distress. They may be coughing, choking, they may have stridor, they may be wheezing, they may not be able to make any noise at all. Most commonly, it's hot dogs, balloons, peanuts, dried foods, peanut butter. Your physical exam, again, sudden onset of respiratory arrest. Therapeutic intervention, depends whether the child is conscious or unconscious. If it's conscious, we're going to do the back blows, abdominal thrust, those sort of things. If it's unconscious, we're going to do CPR and look in their airway every time we go to give the breaths as a single rescuer. As a paramedic, you certainly have the ability with McGill forceps to look in there with a laryngoscope and see if you can see the obstruction, and if so, pull it out with the McGill forceps. Croup. Croup is a viral respiratory infection. It affects the upper respiratory tract. It's below the glottis, so it isn't epiglottitis. It is below the glottis in the upper trachea. The trachea becomes swollen and inflamed. The child is hoarse. They have inspiratory stridor and a seal-like barky cough. It's caused from a respiratory virus, which includes any one of these, either parainfluenza type 1, 2, or 3, influenza A or B, adenovirus, RSV, echovirus, rhinovirus, or a mycoplasma. It's most common cause of upper airway obstruction in children. It affects children 6 months to 6 years, and it peaks at about the age of 2. Parainfluenza virus is most often in the fall, RSV in the midwinter or spring. Remember that it is a virus, and as it is a virus, it certainly can be spread from one person to the next. Has about a 2 to 4 day incubation period. You're going to have a history of an upper respiratory infection for 2 to 3 days. It comes on most often at night. And on physical exam, the child's going to have an increased respiratory rate, maybe an elevated temperature, loud stridor, hoarse voice, that seal-like barky cough, maybe struggling a little bit to breathe with nasal flaring and retractions. Some things that certainly will look like croup include spasmodic croup, epiglottitis, bacterial tracheitis, foreign body airway obstruction, asthma, and anaphylaxis. So you need to rule these out as well, or keep them in your differentials. Therapeutic intervention, you're going to keep them warm and comfortable. Assess them for foreign body airway obstruction via the history only, get a good history on them. Oxygen, if their saturations are not above 95%. Nebulized saline per medical direction, that may help loosen up the secretions, or may help, if it's cool mist, certainly may help decrease some of the inflammation. Watch out for respiratory failure and arrest in real severe cases of croup. Um, Families should have a cool mist humidifier or a steam bath. We always tell them take them outside into the cool, moist night air, and that will help with that seal-like barky cough. And if the moist air does not improve their symptoms, or they are drooling heavily or having trouble swallowing, that's more of an epiglottitis thing, so we have them call 911. Epiglottitis is a bacterial infection of the upper airway, unlike a viral infection of croup. It will cause complete airway obstruction and death within hours. History, you can tell an epiglottic child with epiglottitis even from a distance. They're usually tripoding, heavy secretions, drooling really heavy, unable to swallow because it hurts, high temp, those sort of things. So here they're showing you certainly the difference between epiglottitis on the left, where the epiglottis is swollen, and croup, where the tracheal tissue is swollen. Epiglottitis occurs primarily in 3 to 7-year-olds. It's decreased as a result of immunizing the children, but it's also the reason that we're seeing more epiglottitis in children and adults as well, because of people not getting their flu vaccine. And there is no seasonal preference for epiglottitis. It can occur any time of the year. The history is none really, just a rapid onset. It quickly progresses to respiratory arrest. They may have a quiet, wet stridor, a muffled, hot potato voice, difficulty swallowing. They'll sit upright in the tripod, not coughing. They'll have a real high fever, and nobody else in the family is ill. On physical exam, you have an acutely ill appearance, again, sitting up in the tripod position. They'll be drooling heavily because it hurts so much to swallow. And then a voice, if they're old enough to talk, certainly as if they have a hot potato in the back of their mouth. And it sounds muffled. Shallow breathing. Stridor is a late finding, and it's an indication of a near complete airway obstruction. So when you're hearing stridor in a patient with epiglottitis, you know that their airways are going to swell shut. Some differential diagnoses include croup, laryngitis, bacterial tracheitis, foreign body airway obstruction, and then anaphylaxis. And again, we have to rule these out as well. Therapeutic intervention, you want to observe them, frequently reassess them, make sure that they're comfortable, but don't stick anything in their mouth, don't administer anything by mouth. You can do high concentrations of oxygen if they'll accept a mask. If they won't, you could try some blow-by, and if that doesn't work, you may have to assist their breathing with 100% oxygen. If they do become completely obstructed, it's going to take a lot of high pressure to get around that obstruction in order to ventilate them, and that's where cricothyrotomy may come in. So here's a child. Both of these children, all three of these children, have epiglottitis. And you can see the epiglottis is extremely swollen and inflamed in both those particular views in D and E. Bacterial tracheitis is an acute bacterial infection of the supraglottic area of the upper airway. They're going to have a lot of pus-filled secretions. It's a bacterial upper airway disease. It comes with a high fever, again, pus-like secretions, and they don't have any sort of classic epiglottitis findings. They'll have a history of several days of viral upper respiratory symptoms, rapid onset of a high fever, respiratory distress. They may appear toxic, and drooling is absent. On physical exam, inspiratory stridor, barky, brassy cough, hoarseness, but they're not drooling. They may have some retractions, dyspnea, nasal flaring, and cyanosis. The throat's going to be sore, and then stridor as well as respiratory distress. Differentials, croup or epiglottitis or foreign body airway obstruction. Treatment for bacterial tracheitis, oxygen to keep their sats up above 95%. You may have to assist with a bag valve mask. If you intubate, you want to use 0.5 to 1 millimeter smaller than the calculated for the age because of the swelling that's occurring in the trachea. Frequent suctioning and cardiac monitor. Asthma and reactive airway disease, by description and definition, it is a reversible obstructive airway disease. It's a result of chronic inflammation or hyperactive airways, leading to bronchospasm and heavy secretion of mucus. They can get into in the bronchioles, and so they'll have bronchospasmic episodes where their bronchioles swell, which is what causes the wheezing. It's usually triggered by an allergen or an air pollution, or it can be exercise induced. It could be cold air or an infection. Both the larger and smaller airways are affected by this. Certainly in severe cases with asthma, they're not able to ventilate, and they may get hypoxia. Air trapping, inadequate ventilation, and hypoxemia are present as well, are common as well as hypercapnia and respiratory acidosis. Some risk factors does run in families. Could be a person who infrequently smokes, or a secondhand smoke. That's what passive cigarette smoke is, a secondhand smoke. More common in males than women. May have a history of their mother having asthma. It is or you're at risk of it when you have a viral respiratory infection of having bronchospasm. Smaller airways early in life, low birth weight also increases the risk. History is going to be recurrent respiratory symptoms. It may be induced by exercise or viral infections. They may have allergies to dust mites, mold, smoke, or pollen. It can also be triggered by weather changes or strong emotional depression, or even airborne chemicals or perfumes. Signs and symptoms: wheezing, which could be audible or it could be inspiratory only on auscultation. Dry cough, chest tightness, shortness of breath, retractions, tachypnea, poor air exchange, and a prolonged expiratory phase. It's easy to get air in, it's more difficult to get air out. Some differential diagnosis to asthma could be bronchiolitis, foreign body airway obstruction, a tumor, bronchospasm from some other means, a congestive heart failure, epiglottis, croup, anaphylaxis, and an inhalation injury. Treatment for asthma is going to be position of comfort, give them oxygen to maintain SATs greater than 95%, assist their ventilations if you're not able to get their SATs above 94%, cardiac monitor, bronchodilators. As far as medications that we could administer in severe cases of asthma that's not responding to bronchodilators or regular neb treatments, we could consider IV epinephrine or IV terbutaline per medical direction, and certainly as a last resort, endotracheal intubation. Bronchiolitis is an inflammation of the smaller bronchioles caused by a virus. It produces thick mucus, inflammation, and swelling. So with bronchiolitis, there's going to be some inflammation and swelling of the small bronchi and the bronchioles, excessive secretion of mucus. In children less than 1, RSV is the primary cause of bronchiolitis. It can also be caused by the parainfluenza viruses. History: they have a history of an upper respiratory infection with a runny nose, cough for several days, low-grade temp, and then all of a sudden increasingly have now a productive cough, increasingly get more and more short of breath. They're wheezing at home. They may have a history of an ear infection. They may have been in contact with other children with viral respiratory symptoms, and they may have a family history of asthma or allergies. Signs and symptoms of bronchiolitis: upper respiratory infection, 1 to 3 days of coughing with sneezing, low-grade fever. Now they're wheezing, diffuse rhonchi, fine crackles and rales, wheezes, an increase in respiratory rate, retractions, peripheral cyanosis, and restlessness. They'll also have some tachypnea, tachycardia, and dehydration. Some life-threatening signs. The bronchiolitis is life-threatening. Certainly would be central cyanosis, tachypnea greater than 70 breaths a minute, listlessness, apnea spells, and hyperextended chest that is silent on auscultation, just full of air. Differential diagnosis would be asthma, cystic fibrosis, bronchopulmonary dysplasia, or pneumonia. Therapeutic intervention, SATs, oxygen to maintain SATs above 95%. You may have to assist with a bag valve mask. You may have to use a bronchodilator, which is considered controversial. Nebulized albuterol or epinephrine per medical direction, and endotracheal intubation. Pneumonia is an inflammation or an infection of the lower airway or the lungs. It can be caused by a virus, a bacteria, a parasite, or a fungus. And pneumonia is a primary infection. As far as epidemiology and demographics go, people who are immunocompromised, those with underlying lung disease are at greater risk. All people are at greater risk in the winter months of getting pneumonia. As far as the history goes, this infection may have been preceded by an upper respiratory infection. They may have had a previous bout of fever, malaise, anorexia, and chest pain. Signs and symptoms: fever, chills, malaise, headache, lethargy, anorexia, grunting if the child is trying to maintain PEEP, tachypnea, tachycardia, crackles, retractions, chest pain, and apnea spells. Some differentials. Heart failure may look like pneumonia. In fact, that's the number one most misdiagnosed condition in both adults and children is pneumonia, because it's often related to one of these other differentials where they think it might be acute pulmonary edema from heart failure. Excuse me. Or asthma. Or bronchopulmonary dysplasia or cystic fibrosis. Some therapeutic interventions for the treatment of pneumonia, at least at this time: administer oxygen to maintain SATs above 95%. You may have to assist ventilations if it's not adequate. You may consider endotracheal intubation, and that's something that's being left up to the conscious patient. Is whether or not they, want to be intubated. Some are using CPAP. Some are administering bronchodilators. And certainly if they are febrile, then the need to lower their temperature. Shock, by definition, is inadequate circulation of blood through an organ. Perfusion to me means that blood moves to an organ, through an organ, and exits full of carbon monoxide and waste products. That's what perfusion means, and so shock would be inadequate perfusion. Now, initially, in children, there are some really subtle signs that you're dealing with a child in shock. Irritability and anxiety may be an early indicator. Tachycardia and tachypnea are both early indicators because children compensate so well. Weak peripheral pulses, full central pulses, delayed capillary refill, cool, pale extremities, systolic blood pressure within normal limits as long as they're compensating, and then decreased urinary output. Now, what's being described here is how we learned that all shock looks like: pale, cool, clammy, rapid heart rate, rapid respiratory rate, altered mental status, all those other things. But as we'll talk, there's several different shocks, particularly in children, that they don't even look like this, and you can be fooled and not realize that the patient is in shock. Decompensated shock, others will call this hypotensive shock. In decompensated shock, the signs and symptoms are due to the result of the infant or child not being able to compensate anymore. So the defense mechanisms fail and the blood pressure, cardiac output drops, and then blood pressure drops, and it leads to lethargy, altered mental status, marked tachycardia and bradycardia, absent peripheral pulses, weak central pulses, markedly delayed capillary refills greater than 4 or 5 seconds, cool, pale, dusky, mottled extremities, low blood pressure, and in children that would be a blood pressure less than 70 plus 2 times their age. Markedly decreased urine output if you're monitoring them in a hospital situation, and then cardiac arrest is imminent in those situations. As far as hypotension goes, it's important that we differentiate compensated from decompensated, and that's typically going to be any blood pressure less than 70 plus 2 times their age would be hypotensive or hypotension, and would indicate decompensated shock. Very late sign of shock in children is decompensation, because their hearts are so strong. Now, as far as hypovolemic shock goes, remember that children have smaller blood volumes, so they can't lose as much blood as we can, but hypovolemic shock can be caused by loss of blood, plasma, fluids, electrolytes, endocrine disorders, and then major blood loss causes from internal injury to organs. Signs and symptoms of hypovolemic shock include it can be compensated, where we have all the classic signs and symptoms we just talked about, or decompensated when that systolic blood pressure drops below 70 plus 2 times their age. Look for internal and external bleeding as a cause. Check skin turgor to see if dehydration is a cause. Certainly decreased saliva and tears would be a good sign of dehydration as well. And in babies, you can look at sunken fontanelles. That would indicate the presence of shock. Therapeutic interventions, if it's certainly trauma that's the cause of the shock, we need to immobilize the C-spine, open the airway with a jaw thrust in those that are unresponsive, administer some oxygen, and then effectively oxygenate them and also effectively ventilate them, as measured by pulse oximetry and tidal CO2, and their SAT should be above 95%, and their CO2 should be below 45. Absent pulses, we're going to do chest compressions, apply a cardiac monitor, gain vascular access, administer a fluid bolus for the treatment of hypovolemic shock, and that fluid bolus is 20 mils per kilogram. Remember that 20 mils per kilo is a 25% is 25% of their blood volume. So by giving them a 20 mil per kilo bolus, we in essence have replaced 25% of their blood volume with salt water. Now that's a good thing, that isotonic crystalloid, if their volume loss is vomiting, diarrhea, sweating, that sort of stuff, but it's not a good thing if their volume loss is related to blood. Also check their blood glucose level, because low blood sugars will cause altered mental status as well. And I can't stress enough the importance of maintaining normal body temperature in children who are hypovolemic. We don't think much about that, but it is so vitally important. Shock, by definition, is lack of adequate tissue oxygenation, so they're not getting enough oxygen to their vital organs. And then if we allow them to get cold and their body senses that and begins to shiver, the shivering is going to consume lots of energy, energy that they don't have because they're not able to perfuse their vital organs the way it is, and we're just going to worsen the shock. Distributive shock can be caused by a severe infection or a severe allergic reaction or a spinal cord injury or certain medication overdoses. When we think of distributive shock, this one will fool you because the skin is warm and flushed. The pulse rate may be normal. There may be brisk capillary refill. And that's because in distributive shock, they aren't losing any blood. The blood is being distributed to other parts of the body. During septic shock, expect fever, tachycardia, vasodilation, mental status change, inconsolability. And there's essentially two stages of sepsis. There's the hyperdynamic state of sepsis, which is also called warm shock, and then the hypodynamic state of sepsis, which is also called cold shock. We want to make sure that in septic shock, excuse me, because shock is lack of adequate tissue perfusion, that we make sure that we are not only effectively not only administering oxygen like we've all been taught to do, but making sure that their ventilations are adequate, and if they're not, to restore those adequate ventilations. Keep their SATs above 95%, their end-tidal CO2 is less than 45, and if they don't have a pulse with this shock, you're going to do CPR. But if they're unresponsive and have a heart rate less than 60, you're still going to do chest compressions. SIRS, systemic inflammatory response syndrome, is a precursor to sepsis and is present when you have three of these four things: tachycardia, tachypnea, temperature greater than 101.4, and the last one is a white count elevated above 12,000. So if you have three of those four things, you're preseptic. Anaphylactic shock is certainly a life and death emergency as well. It is caused by an over exaggeration of your immune system when you are exposed to a foreign protein that your body sees as harmful and releases histamine and bradykinin and several other chemicals that lead to this type of shock. We'll look at the signs and symptoms of anaphylaxis, the causes, as well as just like with all shock, adequately oxygenate and ventilate, apply a pulse oximeter, end-tidal CO2 monitor, keep their SATs above 95%, their end-tidal less than 45, and again, if an absent pulse or heart rate or pulse is less than 60 in an unresponsive child, we need to be doing chest compressions. I'm going to go back because it doesn't look like they're going to break down the signs and symptoms of anaphylactic shock. It's important that we differentiate between an allergic reaction, which is hives, itchy skin, watery eyes, runny nose, sneezing, those sort of things, and anaphylaxis, which is all of those things we just mentioned, plus a systemic involvement where the chest is tight, they can't breathe, their blood pressure's dropping, those sort of things. We're going to have them on a cardiac monitor. We can give them epinephrine intramuscularly. This is an older slide, certainly in referencing subcutaneous administration of epinephrine in anaphylactic shock. Shock is a state of inadequate tissue perfusion, and certainly the tissue that is being perfused the least is going to be fat. So if you're giving a subcutaneous injection of epinephrine into the fatty tissue, it's going to take a long time to get into the bloodstream. So we give it intramuscularly, and in very severe situations, you can give it intravenously. They may be administered a bronchodilator, an antihistamine, a steroid. All those sort of things will help improve their breathing, and the antihistamine will stop the cause of the anaphylaxis. When we give the epinephrine, that's going to vasoconstrict, make your heart beat stronger as a pump, which is going to help keep your blood pressure up so you don't go into shock. It's also going to dilate your bronchioles a bit. And then we follow that up with a albuterol treatment and an antihistamine like diphenhydramine, and then a corticosteroid. You're going to have vascular access, whether it be IV or IO. monitor for worker breathing. How hard are they working through this? And if it is hard for them to breathe through this, and their SATs aren't improving, their untitled CO2s aren't improving, the patient's level of consciousness isn't improving, then we need to prepare for some advanced cardiac life support. Get a blood glucose level as well. Neurogenic shock is caused by severe head and spinal cord injuries. In this case, they lose sympathetic vascular tone below the spinal cord injury, and all the smooth muscle fully dilates. So all your blood vessels fully dilate below the spinal cord injury. But it may not be the result of a cord injury. Neurogenic shock can be the result of certain medications in the medical patient, tumors in the medical patient. In any event, if you suspect neurogenic shock, and this will fool you too, because if it's high in the back, you're going to have pink, flushed, warm skin. You're going to have brisk capillary refill. Pulses are typically bradycardic with this, which is the reverse of shock as well, as we know it. So this one will fool you as well. Administer oxygen to maintain SATs above 95%, untitled CO2 to monitoring to make sure that stays around 45. And again, like all shocky patients, if you've got a child who is heart rate less than 60, then we need to be doing chest compressions. You're going to want to apply a cardiac monitor, gain IVIO access, give a 20 ml per kilo isotonic crystalloid solution to this child in order to fill the container a bit. If that doesn't work, you certainly can give them another one and monitor their lungs to make sure that they aren't developing some acute pulmonary edema from all the fluid that we're giving them. And then maintain normal body temperature, prevent hypothermia, check their blood glucose level. Obstructive shock can be caused by any of these things: cardiac tamponade, tension pneumothorax, massive pulmonary embolism, obstruction of blood flow from the heart. So cardiac tamponade, tension pneumothorax, massive pulmonary embolus, all of these obstruct the flow of blood, and that's why they're called obstructive shock. You've not lost any blood. It hasn't been redistributed somewhere else. You just can't move it. We're going to immobilize the C-spine, open the airway with a jaw thrust, make sure that we're adequately oxygenating and ventilating them, apply a pulse oximeter, and remember with PEs, the pulse ox is going to be low, and there's not going to be much improvement in saturation, even with 100% oxygen. Keep their SATs above 95%. It is considered what do I want to say? If the pulse is absent and the heart rate's less than 60, we're going to do chest compressions. You want to gain vascular access. You want to listen to lung sounds. And if you believe they have a tension pneumothorax, go ahead and needle decompress the chest. Cardiogenic shock is the last shock that we'll talk about, and this is when the heart fails as a pump. Rates that are really slow will cause cardiogenic shock. Rates that are really fast will cause cardiogenic shock. And then certainly pump failure itself, some sort of viral infection of the heart will cause a cardiogenic shock. With cardiogenic shock, you get both oxygenation, ventilation, and perfusion deficits, because if the pump isn't working well, that's going to be a decrease in blood pressure. If it's left-sided heart failure, then blood's going to back up into the lungs, causing an acute pulmonary edema, which is going to make it very difficult to oxygenate. Cardiogenic shock is leading to cardiopulmonary failure, and the next step after that would be cardiac arrest when children are bradycardic and their respirations are irregular or ineffective. When their sudden increase in work of breathing begins to decrease. Their capillary refill time becomes delayed. They become severely bradycardic. They get weak central pulses and absent peripheral pulses. Extremities get cool, mottled. They develop a diminished level of consciousness. And one of the keys here in cardiogenic shock is if that left side of that heart fails, they're going to develop acute pulmonary edema, so they're going to have crackles. Causes of cardiogenic shock in children include cardiomyopathy, severe congenital heart disease, myocardial dysfunction after cardiac surgery, myocardial trauma, heart failure, hypothermia, drug intervention or drug intoxication. Severe electrolyte imbalances. The heart does not work well at all as a pump if it's being bathed in acid or very strong bases. Cardiac dysrhythmias, again, very fast heart rates and very slow heart rates will cause cardiogenic shock. And remember that bradycardia, when you see bradycardia in a child, that it's often due to hypoxia, secondary to respiratory arrest or asphyxia. Tachydysrhythmias that we'll look at in PALS include unstable dysrhythmias like sinus tachycardia, supraventricular tachycardia, and VTach. Bradydysrhythmias that are too slow, those are usually caused by structural heart disease. Secondary would be a non-cardiac cause, and they're going to lead to decreased cardiac output that produces hemodynamic compromise. Bradydysrhythmias here that are caused primarily by structural heart disease are rare. They're extremely rare. Bradycardia in children is almost always caused by hypoxia. And so when we see bradycardia or bradyarrhythmias, the first thing we want to think about is hypoxia. Absent or pulseless rhythms in children include cardiac arrest, and when you apply a monitor, you'll see things like ventricular fibrillation, pulseless VTach, asystole, and pulseless electrical activity. We've already mentioned that cardiogenic shock can be caused by dysrhythmias, those that are too fast and those that are too slow. So here's an example of a supraventricular tachycardia in children. And you can see that the rate is about 210, 240. The rate's right up there around 240. The complexes are narrow. And you can see that in B, the rhythm converted. It doesn't look like it's been converted by electrical therapy, or there'd be a big spike right before that rate slows down in the strip labeled B. This could be certainly something that adenosine may do, and we'll talk in detail what we can use the adenosine for. Seizures in children, postdictal are going to lead to an altered mental status. Seizures can be epileptic, or they can be caused by hypoxia, head trauma, infections, hypoglycemia, drug or alcohol ingestion. Over 50% of all seizures are idiopathic. In other words, they have no idea what causes them. 25% are epilepsies, and 25% are caused by some of these things you see here. The altered mental status associated with a seizure, the child will be agitated, irritable, confused, moaning, frightened, maybe hard to wake up. You may find them with abnormal work of breathing or pallor, or abnormal muscle tone, or abnormal body position for their age. There's a variety of different types of seizures, and a seizure by definition is a massive massive uncontrolled discharge of neurons in the brain. And these massive uncontrolled discharge can occur in one lobe, can occur in a small portion of the brain, can occur in one hemisphere, can occur in both hemispheres. And depending upon where these occur, gives me an idea of what type of seizure it is. Seizures can be simple. A simple partial seizure is the twitching of just one part of the body, like maybe the twitching of a lip, or the twitching of the eye, or the twitching of an arm or a leg. They could be complex. Complex partial seizures are they're almost like a psychotic event. The patient is awake but unaware of their surroundings. They're walking around. They may be uttering, muttering, throwing things, using profanity, wringing their hands, picking at stuff, that sort of stuff. So it looks like a psychotic event. And then generalized seizures are they involve both hemispheres, and as a result of involving both hemispheres, the patient's going to be unconscious. You can have tonic seizures, clonic seizures, tonic-clonic seizures, myoclonic seizures, and they all present differently. Status epilepticus is a situation where you have seizure after seizure after seizure without full recovery. We know that during a seizure that breathing is inadequate. So if they seize without recovery, then they can become severely hypoxic, severely hypercapnic, go into respiratory arrest and cardiac arrest. So status epilepticus is a life-threatening situation. Febrile seizures are related to body temperature, and it isn't so much how hot the child is, it's how fast it gets there. We already looked at these causes of seizures already. We'll review them again. Head trauma, toxins, hypoxia, high fevers, hypoglycemia. Now, hypoglycemia can cause a seizure, but hypoglycemia can also be caused by a seizure. Following any seizure activity, it's extremely important to get a blood glucose in children. Could be an infection like a meningitis. Could be a metabolic disorder like metabolic acidosis or alkalosis. Could be a brain tumor or abscess. Could be a stroke, although strokes are extremely rare in children. Could be a cardiac dysrhythmia, or could be genetic or hereditary. On physical exam, post-ictal, when you arrive, if they're not seizing and you see the tonic-clonic activity, good indication that they did have a grand mal or tonic-clonic seizure, generalized seizure, is tongue biting, bumping of the head, and incontinence of urine and stool. They may have a medical alert bracelet if they're an epileptic. They may have burns, particularly if they were drinking hot soup, hot coffee, those sort of things. Not that children drink hot coffee, but a hot drink, hot soup. And they may have a history of a bump to the head. Differential diagnosis, certainly hypoglycemia, syncope, dysrhythmias, tetralogy spells in children who suffer from that heart condition, breath holding spells. You'll get children that will hold their breath in retaliation for something they want and didn't get, and they'll have fits and kick and scream and hold their breath and end up having a syncopal episode and then being post-ictal afterwards. Acute intoxication and then pseudo seizures. Therapeutic intervention, protect the patient, prevent them from injury. If they are in a grand mal tonic-clonic seizure, certainly putting a pillow or something under their head and moving things out of the way so that they don't get hurt. Roll them up onto their side so that should they aspirate during their seizure, they're less likely to suck it down into their lungs. Should they vomit during their seizure, they're less likely to aspirate it. Don't put anything in their mouth. Trying to force a tongue depressor or a tongue blade into their mouth could break teeth off. If you put your fingers in there, you could get them partially bitten off. Just don't put anything in their mouth while they're seizing. Don't try to restrain them. You can break bones. Give them high flow oxygen. You may have to assist their ventilation, particularly post-ictal. Apply an ECG monitor. Check for their blood sugar. And status epilepticus is going to require you to start an IV or an IO and give medications to stop it. In addition to IVIO, we certainly can give things both intranasally and rectally in children suffering from seizures. Hypoglycemia occurs in children when they're metabolically stressed. It can cause prolonged irreversible brain damage. Can also be caused by alcohol intoxication in children. It can also be caused by a diabetic child who gets too much insulin and then doesn't eat or over-exercises or is under great physical or emotional stress after taking their insulin. And they may eat, but if they eat the wrong things, that can lead to hypoglycemia as well. Signs and symptoms, we used to call hypoglycemia insulin shock because it was related to giving too much insulin, and the patient looked just like they were in shock. They were pale, cool, sweaty. They had an increase in respiratory rate. They were tachycardic. It was rapid in onset. They'll have a normal breath odor if you can smell those things. Tremors, staring, inability to concentrate, incoordination, irritability. And we're going to monitor their ABCs, administer some oxygen, IV or IO, and then give them some sugar if their sugars are low. So when we get into the PALS, we'll talk about, in children we give D25 and in infants we give D10. We'll talk about how to mix that all up and how much to give. Some differential diagnoses that we need to keep in mind with hypoglycemia. It does resemble alcohol intoxication, electrolyte disorders, drug overdose, infections, poisonings. And again, we're going to start an IV, give dextrose if their sugar's less than 60 milligrams per deciliter, either D25 or D10. If we can't get an IV or an IO established, then certainly we could administer glucagon, and if they have sugar stores in their liver, it will raise their blood glucose, but only for a short period of time. Recheck their vital signs often, and recheck their blood glucose 10 minutes after therapy. Remember that if you do give them sugar, it's going to rapidly go into the cell where it's needed, and their blood sugar level is going to drop again. So once you get them awake and they can swallow, you might want to consider giving them a carbohydrate. And we use a rule of 15 where we'll give them the sugar that we're supposed to give them when they wake up and can swallow and eat. We'll give them 15 grams of carbohydrates. Hyperglycemia occurs when you have excess glucose in the blood. It's going to lead to dehydration and eventually ketoacidosis. We'll often see the dehydration. The patient may or may not be in ketoacidosis, but certainly will be severely dehydrated, unresponsive, and will need our help. Hyperglycemia is caused when the blood glucose levels get too high in a non-diagnosed diabetic patient. That's often how they are diagnosed, by a high blood sugar. If they don't take enough insulin, if they eat the wrong foods or too much food, or if they're under emotional stress or have an infection. Anytime that you're sick or anytime that you're emotionally stressed, your body is going to raise its own blood glucose level by releasing sugar stores to help you fight or combat that stress or that illness. Excessive food intake containing sugar will also raise your blood glucose and increase your risk of diabetes. Insufficient insulin dosage, as we mentioned, infection, emotional stress, as we mentioned, surgery. But in any event, when a person has hyperglycemia, regardless of age, they get the polys. Polydipsia. they're constantly thirsty. Polyuria, they're constantly peeing. Polyphagia, they're constantly hungry. Even though they've got lots of sugar in their cells, they cannot get it to their, even though they have a lot of sugar in their blood, they can't get it into their cells. And so their body cells see that as they're starving and they need energy. So they feel like they're constantly hungry, like they can't get enough to eat. On physical exam, they'll have a slight respiratory rate increase, which may develop into what's called Kussmaul's respirations, very deep, very rapid. They'll be tachycardic because of the dehydration. Their blood pressure will be decreased because of the dehydration. They'll be dry. Their mucous membranes will be dry. If it's an infant, the fontanelles will be sunken in. They'll have poor skin turgor. Their abdomen may be tender and distended as well as a result of the hyperglycemia. Some differential diagnosis, vomiting and diarrhea, altered mental status causes, all those AEIOU tips that we talk about as common causes for altered mental status. With hyperglycemia, the key for us in the pre-hospital environment is going to be supportive by opening the airway, suctioning, positioning. If they're unresponsive, give them high flow oxygen, monitor their end-tidal CO2 and pulse oximeter and heart rate. Check their blood glucose level. If your glucometer is going HHH, you know it's off the chart, at least greater than 300. But look for signs of dehydration. And if they are dehydrated, IV access, give them a 20 mil per kilo bolus of normal saline. We give that over about 5 or 30 minutes. We don't want to give it fast, or we can actually precipitate cerebral edema. And giving a 20 mil per kilo bolus is 25% of their blood volume. So you've just replaced 25% of their blood volume with saline, and you should see some sort of response. If not, you can give some more. Meningitis is an inflammation of the meninges. If you remember, the meninges are the coverings that go over the brain and the spinal cord. They include the dura mater, the arachnoid membrane, and the pia mater. The infection can spread very quickly. There was a commercial a while back that said, this is what a 14-year-old girl looks like 1 hour prior to dying from meningitis. And she was playing on the playground, laughing, smiling. You had no indication whatsoever that she was sick. And within an hour, she was dead from meningitis. The brain becomes swollen. It becomes covered with pus. It can happen in newborns and older children as well. There is a vaccination for it. It can be bacterial or viral. It'll be a sudden onset. If it's typically it's a sudden onset. They may have a history of a recent ear or upper respiratory infection. They'll have a fever. In neonates, they're going to be in respiratory distress or apnea as a result of this. They'll have vomiting, a headache, poor feeding, photophobia, altered mental status, excessive lethargy or irritability. Fevers, tachycardia, sore throat, runny nose, tachypnea, cool, clammy skin, petechiae, respiratory distress, poor feeding, vomiting, dehydration, shock, purpura, seizures, severe headaches, irritability, stiff neck, and bulging fontanelles. If you look at these signs and symptoms for meningitis, they're in the severe stages. With the petechiae, the purpura, the shock, the seizures, that certainly is a situation where they're not likely going to survive that. But early meningitis looks just like an upper respiratory infection, like a common cold. They may also have a stiff neck. We call that nuchal rigidity. They're unable to touch their chin to their chest because when they do, that stretches the meninges of the spine and causes severe pain. May resemble pneumonia initially, hantavirus, a drug reaction, blood disorder, or Kawasaki disease. Therapeutic intervention, because this could be bacterial or viral, and you don't want to get meningitis. Good personal protective equipment, wearing a mask, and on you and an oxygen mask on the child. Monitor their ABCs. If there's lots of secretion, suction the airway, position them in a position of comfort if they're awake. Monitor for seizures, administer oxygen, hook up a cardiac monitor, a pulse oximeter, Untitled CO2. If there certainly have been feverish, throwing up, diarrhea, and look dehydrated, then give them an IV fluid bolus and then reassess. Poisonings and toxic exposures. Kids are curious by nature. They're quite mobile as well. As they get around, then, excuse me, I have a visitor. Okay, as I had mentioned, when we talk about poisoning and toxic exposure, kids are curious by nature. Everything they get in their early ages of their life, they want to smell, touch, feel, taste, that sort of stuff. And as they become more mobile, the potential for poisoning and toxic exposure increases. It could be exposure to the environment. They could imitate the behavior of an adult when it comes to drinking alcohol or smoking or even illegal drug use. Children may be attached or attracted to the packaging of the item as well. Okay. Poisonings occur primarily in kids under 6. When you get older than that, you start getting into your adolescence, those sort of things. Chemical and drug abuse are a common cause of poisoning. Suicide attempts as well. Unintentional death is uncommon, particularly in smaller children. Most of the things that they can get into as far as poisoning goes taste bad. So when they put them in their mouth, it's not likely that they're going to swallow much of it at all. They usually end up spilling it all down the front of their clothing, and then when you get there, you're uncertain of how much they actually took in, and so calling poison control would be a wonderful thing to do. Physical exam, look for mental status changes that would indicate they got enough of it into their system. Check their vital signs. Maybe you can smell the odor of whatever it is they got into. If they've got an altered mental status, be alert for vomiting and seizures. And if they aspirated whatever it is that they took into their lungs, they can quickly develop stridor and airway obstruction from the lung damage and the aspiration of whatever it is they got into. You can give them oxygen if necessary, either by blow-by or non-rebreather mask or a bag mask with 100%. Attach your cardiac monitor, call the poison control center, establish an IV or an IO, bring the container to the hospital with you. That poisoning got out of sync with this meningitis, or the meningitis got out of sync with the poisoning one. On physical exam in a child with meningitis, you can see here, this to me looks more like a septic child, which meningitis in the very late stages is sepsis, because what you see on the child in A is purpura. Purpura is a purplish, non-blanching rash that is unlike hives, where hives will blanch and they're raised and they're red. These are more purple, and they're a good indicator of the terminal stage of sepsis. In B, you can see the little red dots or the little red spots along with some purpura. Those little red spots are petechiae. Falls can also cause falls is a very common cause of pediatric trauma, and how bad the child is injured as a result of the fall depends on things like how far did they fall from, how much did the child weigh, what did they land on, what part of the body hit the surface first, Were they wearing any protective equipment? Motor vehicle collision crashes, again, are also a common cause of pediatric trauma. In fact, the most common. Depending on the type of the collision, whether it was frontal, rear end, rotational, ejection, all those things play into the potential for serious injury. Where the position inside the vehicle was of the child, whether or not they were using restraints, and were those restraints used appropriately. If seatbelts aren't worn appropriately, certainly can cause blunt abdominal trauma. They can have neck and spinal cord injury because of their very large heads, particularly in a rear end collision where whiplash is part of it. As far as motor vehicle and pedestrian crashes, common mostly in the 5 to 9 years of age. Most common death cause from trauma in that age group is motor vehicle and pedestrian crashes. If it's less than 5 years, they are often run over in their own driveway. Factors that affect certainly the severity of the injury, how fast the vehicle was going, what the initial impact point was, and as our vehicles get higher and higher, those impact points change, and we see different patterns of injury. Additional impact points: if the child is struck by the bumper and then thrown up onto the hood and then into the windshield and then down to the ground, those are all additional impact points. The height, the weight of the child, and what surface they landed on. The impact phases. Remember with children that children have a tendency to turn and face the impact, the vehicle. Adults have a tendency to run away, but children have a tendency just to turn like a deer in the headlights and face the vehicle. So, where the bumper would be in relationship to where the child stood is going to be your first point of impact. They can be thrown up, as I mentioned, into the hood and the windshield, or they can go under the car and be run over. Bicycle injuries occur in the 5 to 14 years of age. Most common injury there is head trauma, next to facial and extremity trauma, abdominal injuries on the handlebars, and helmets would go a long way in preventing most of those types of injuries. Traumatic brain injuries can occur in children. Linear skull fractures. Linear skull fractures are cracks in the skull, and so we may not be able to see those at all unless we have an x-ray, and even then it may be difficult. But what you may see is an overlying hematoma with a lot of soft tissue swelling. Linear skull fractures are common when a child falls to the ground, again because of the big size of their head and lack of strength of their neck to support their head. So they may whack that ground pretty hard with their head. If they have an epidural hematoma above the dura, between the skull and the dura, that is primarily arterial bleeding. So epidural hematomas have a classic presentation: a blow to the side of the head, an immediate loss of consciousness. They slowly regain consciousness and then they go out again. Below the dura, actually get into subdural, subarachnoid hemorrhages. Those are typically venous bleeding, are much slow and may take days or weeks to show that they have them. Subdural hematomas less than 1 year age, and 93% may have subdural hematomas. Shaken baby syndrome, cerebral contusion, swelling, focal seizures may cause those as well. Decreased consciousness, bulging fontanelles, weak cry, pallor, vomiting, retinal hemorrhages are all indications of subdural hematomas. Intracranial pressure signs and brain herniation signs is what you'll look for here. As the mass increases, it's blood, it's non-compressible, so intracranial pressure is going to rise. And signs of a rise in intracranial pressure, the number one sign is an altered mental status, followed by blown pupil, posturing, Cheyne-Stokes breathing, and those would all be signs that the pressure is high and that the brain is herniating. With traumatic brain injury as well, If we suspect cervical spine, we want to put them into a neutral position, not hyperflexed or hyperextended. Prevent hypoxia, jaw thrust without head tilt, suction, oxygen, intubate, and lidocaine is no longer recommended. It was recommended to blunt the rise in intracranial pressure that occurred during intubation, but that just has not been shown to be effective and is no longer recommended. Control external bleeding, because they certainly could have significant bleeding from the head in their children, so they don't have a lot of blood to lose. They may begin projectile vomiting within 30 to 60 minutes of a good head injury. So, having an oral gastric tube in place in the hospital so that they can decompress and evacuate the stomach would be good. Start an IV. If they are hypotensive, look for bleeding somewhere else inside the body. Head injuries rarely ever cause hypotension. If they have seizures, you treat it just like we talked about treating seizures. Frequent neurochecks, a fall of 2 points in the Glasgow-Coma scale is a good indicator of a significant deterioration in a patient with a head injury. And then rapid transport to a neuro center. In those children less than 8 years of age, C1 and C2 are the most common injuries. Greater than 8, we look at C5 through C7. But what's interesting with these children is that they can have spinal nerve injury without any sort of vertebrae injury, and it's called spinal cord injury without radiological abnormalities. There it is. SCIWRA. Signs and symptoms certainly of spine trauma, neck and back pain, movement with pain. Movement causes pain in the neck and back. Posterior neck, midline, back pain on palpation. So you're palpating the back of the neck, you're palpating the midline, and it causes pain. Or if there's a deformity of the spinal column, if they're splinting or guarding, priapism, neurogenic shock is caused by spinal cord trauma, paralysis, paresis, numbness of the arms and legs, tingling, diaphragmatic breathing if the phrenic nerve is severed. We're going to stabilize them with spinal cord injury using pediatric appropriate equipment. And these type of patients, we're going to immobilize the spine. Mechanism of injuries involving blunt trauma. Mechanism of injuries resulted in a rapid forceful head movement. Altered mental status with trauma following drowning. Neurologic deficits in the arms or legs. Helmet damage. And then any sort of tenderness in the cervical, thoracic, or lumbar region. Combative child is going to be very difficult to immobilize, and so it may not be worth the effort to do that. In fact, the benefit of forcefully trying to restrain a child far outweighs the risks of worsening a spinal cord injury. If they've got penetrating foreign body to the neck with hemorrhage, we don't do spinal immobilization unless there are obvious signs of spinal cord injury. Massive cervical swelling can, of course, lead to airway obstruction as well. Just want to make sure that we prevent secondary spinal cord or brain injury by adequately oxygenating and ventilating these patients. Mobilize the head and the neck in a neutral inline position, apply a rigid cervical collar, log roll them onto a backboard, secure the chest, the pelvis, and the legs, secure the head last. Safety seat can be used, and most it's split. Some camps will say if the safety seat is not damaged and the child is in not need of resuscitation, then you can keep them in. Others say the manufacturer only agrees to protect that child in one crash. So if you're reusing it again, and you get in a crash, there's no guarantee that seat is going to function as it's supposed to. pad the open voids, cravat around the head to tie him into the safety seat. Chest trauma carries a high mortality in children. It leads to pulmonary contusions and pulmonary lacerations. Can lead to pneumothorax and hemothorax. Rib and sternal fractures are not common, and if they are, it takes a significant amount of pressure to do that, or force to do that, because their bones are so pliable. And I would be more concerned with the potential for a pneumothorax or a hemothorax or a hemopneumo or a big pulmonary contusion or a lacerated lung when rib and sternal fractures are present. They can have a myocardial contusion. They can have a diaphragmatic herniation. They can sever their aorta just like adult patients can as well. Again, rib fractures take a significant force to do, and so you want to look at where that injury to the chest is, and left lower, you might be dealing with a spleen injury, right lower, a liver injury. Multiple rib fractures, you're going to end up with inadequate breathing, and the inadequate breathing may lead to a pneumonia. Flail chest is certainly life-threatening, not so much because this little segment isn't moving up and down, but because of the huge pulmonary contusion that's caused below that flail and the inadequate mechanism of breathing. So restoring that is important. Pulmonary contusions are easily missed because we can't see them, but anytime you have chest trauma with a significant mechanism, you've got a pulmonary contusion. Tension pneumothorax is an immediate threat to life. You're going to have to listen out under the armpits in order to hear whether or not they're moving air, because if I listen to the center of a chest, particularly a tiny chest, the air movement I'm going to hear is going to be, I don't know whether it's coming from left or right. Massive hemothoraxes are rare in children. In fact, exsanguination is rare in children. In order to have jugular vein distension, you have to have normal amounts of blood. So if a child is bleeding, jugular vein distension will be absent even with a tension pneumothorax. Bradycardia from the hypoxia means arrest is imminent. Assist with bag mask ventilation. You may have to intubate them, seal open pneumothorax, put holes in the chest with a suspected tension, and rapid transport. Abdominal and pelvic trauma. Abdominal wall is very thin. The organs are really close together, and motor vehicle collisions are the most common cause of blunt abdominal trauma. And typically they'll rupture a spleen or they'll rupture a liver as a result of improperly wearing a seatbelt, leading to a lethal internal hemorrhage. It also causes kidney injuries as well. Their organs are so close together that blunt trauma in particular can damage multiple organs. If you take an adult and you hit him on the left side of the abdomen, you might get their spleen. Whereas if you hit a kid on the left side of the abdomen, you're likely to get their spleen, their pancreas, their liver, because everything is so close together. Management for abdominal and pelvic trauma. Again, this would be things that occur inside that we can't see, so look for signs of shock. Be supportive. As long as you've got palpable radial pulses, there is no reason to give IV fluids. Green stick fractures. Children often suffer green stick fractures because their bones are so green, because they are so they just don't snap. They don't break like normal. They splinter. It can cause a growth plate injury, in which case the extremity would not grow. Bilateral femur fractures in any child should be certainly an indication of child abuse. Extremity trauma, control external hemorrhage and splint. Immobilize the joint above and below the injury, CMS before and after. If the blood loss was significant to cause shock, certainly consider some IV fluids, but only if you're having trouble palpating radial pulses or the pressure is less than 90. Okay. Burns, you can have chemical burns from household products, electrical burns from biting an extension cord, in addition to burns to the mouth, the potential for ventricular fibrillation. Burns require rapid hospitalization on children, and whether they're chemical or electrical, we often don't know the extent of the burns because it's occurring inside. And in those situations, we want to get them to a hospital. If they've got any sort of burns to the face, then intubating the trachea would be a good thing before that trachea swells shut. Assess for signs of shock. Apply a cardiac monitor. No ice, no wet sheets. You can cool a very small burn. A small burn is defined as less than 10% of their body surface area. So we use that rule of palms, less than one palm. Their palm is 1% of their body surface area. So if the burn is less than 10 of their palm sizes, then it's a small burn, and you could put something cool on it initially, and then wrap it in. If it's amenable, wrap it in Saran wrap. Saran wrap, you can see the burn, you can keep the heat in, keep the bugs out, that sort of stuff. Drowning, the most important thing that we need to do with a child who's been pulled from a lake or a pond is to begin ventilating right away. The sooner we can begin ventilating, the better it is for the patient. We're really struggling with anoxia and severe brain damage. So the sooner we can correct that, the better chance they'll have of coming out without a lot of brain damage. The factors that affect the outcome or how well the child's going to do include the temperature of the water. It's got to be really, really cold, and the child has to cool down really, really fast before that mammalian diving reflex really makes a difference. The duration, the degree of hypothermia, again, the quicker they get cold, the colder they are, the better it is for them. That mammalian diving reflex is also called the mammalian diving reflex. Younger do better, fare better than older children when it comes to that, and that's most likely because they cool down faster. Again, that whole diving reflex works only in smaller children and only in really, really cold water. If the water's contaminated, if it's stagnant water and they aspirate that into their lungs, certainly the risk of a pneumonitis or a pneumonia is going to be there, and they may survive the drowning only to die from acute respiratory distress syndrome. How long they've been in cardiac arrest, how quick the initial ventilations occurred, and how well they resuscitated the brain. So general management of drowning is to restore the ABCs, begin ventilation in the water if necessary, start with rescue breathing, keep the neck in line and stable, 100% oxygen, intubate, positive pressure ventilation, attach a pulse oximeter if you get pulses back, and immersion hypothermia occurs when they're in cold water too long, and it may lead to the drowning as well. Cardiac monitor, do CPR if they cannot palpate a pulse. May take a full minute to check for that. Gain IV access. I wouldn't necessarily give them a fluid bolus unless there was something in the history that would indicate that they were hypovolemic when they went into the water. Assess their blood sugar and rapid transport. As far as maintaining the airway, it's maintained in a inline, stable, neutral position. We don't put them into a hyper extended position like we do adults. We should give them 100% oxygen during trauma, open the airway, suction, jaw thrust, assist in effective breathing, intubate inadequate airways, put a gastric tube in, especially if you're going to be bag valve masking them for any length of time. Now, a gastric tube is not within the scope of practice of a paramedic. It used to be, but they just recently took it out. Needle cricothyrotomy is rarely indicated to manage the airway. As far as immobilization goes, rigid C-collar, towel and blanket rolls, child safety seat, KED, pediatric specific immobilization device. We can use longboards, adult longboards, but we got to pad the voids and tie them down with straps and cravats. But in any event, if we're thinking immobilization for spine trauma, don't flex the neck. Fluid management in pediatric trauma, IVIO access. The fluid boluses are 20 mils per kilo. Reassess after each bolus. You can give up to 3. Analgesia and sedation, as far as pain, should be assessed in all patients. Typically in children older than 3, they'll tell you when they hurt. You can use the Wong-Baker-Faces pain rating scale to determine how severe their pain is, and contact medical control before administering analgesics to children, whether they be morphine or fentanyl. Here's the Wong-Baker-Faces, and depending upon the face that the child is making, you might get an idea of how severe the pain is. Child abuse, you all have taken child abuse classes. You are a mandatory reporter, and the terminology for child abuse that they're talking about here is maltreatment, which primarily includes physical abuse and physical neglect, emotional abuse, emotional neglect, and sexual abuse. Neglect can be the failure to provide for basic needs when you have the resources to do so, and it could be physical, could be educational, could be emotional, could be as part of their healthcare needs as well. Physical abuse is inflicting a non-accidental injury that's inconsistent with the history given. Emotional abuse is very difficult to prove, but occurs more frequently than we think, and that is certainly anytime you convey that the child is worthless in any variety of ways, shapes, or forms. If a child's told that they're worthless long enough, they become worthless. Terminology, there's accidental injuries versus inflicted injury, and you're going to use the history to determine whether it fits the type of injury. Mongolian spots are spots that do occur on some children and are not abuse. Ehlers-Danlos syndrome, we'll have to look that one up. Blood disorders may cause children to bruise easy. Impetigo may look like there was one case where a human had bit their children, and an adult had bit their children, and rather than saying that it was dog bites, said it was impetigo. And when you looked at the pictures, it was really difficult to tell that, that could have been impetigo. It certainly looked like impetigo, but it ended up being human bites. Chickenpox, KOGO as well. I'm going to have to look up Ehlers-Danlos syndrome and the KOGO. There is a baby with Mongolian spots. You can see all the dark, discolored spots all over the body. Accidental versus inflicted. Kids are going to injure themselves because they're curious about their environment. They're going to get into things, and they can injure themselves. If this turned out to be a cigarette burn on the end of the nose of a child, then you'd have to be suspect that this would be abuse. SIDS is sudden infant death syndrome. That's the unexplained death of an infant, and it remains unexplained. On autopsy, they have no idea why these infants die. They think perhaps it could be a respiratory tract infection that triggers hypoxia, and the hypoxia causes them to become bradycardic and go into asystolic. May also be caused from increased reactivity of the pulmonary airways or the pulmonary vessels. Maternal risk factors, if the parent is young at age, if they've had multiple children, if they smoked during their pregnancy, if they abused drugs, if they had previous SIDS deaths, if they were anemic during the pregnancy, and that's odd because they're relatively anemic. In the third trimester, they increase their blood volume by 25%, but their red cells don't increase by 25%. Low socioeconomic status, low family income, short interval between pregnancies, they may not be married, late attendance at a prenatal clinic, postnatal depression, and certainly following a SIDS death, there may need to be the need for a psychiatrist. Infant risk factors, more males than females, low birth weight, low birth length, premature birth, blood type B, low APGAR scores at birth, low hematocrit at 48 hours. When they're put in the prone sleeping position, flat on their back, if they're overheated, not breastfed, increases the risk of SIDS, if they've had a previous cyanotic episode, or if SIDS was previous in the family. Interventions. Appearance, work of breathing, and circulation. You're going to use that pediatric assessment triangle, perform your initial assessment. The child will be pulseless and apneic. They may have dried stuff around their mouth. And it'll be your decision whether or not you're going to start CPR. Use the baby's name to let the parent know that the child had a name and meant something. Document your resuscitation efforts, explain your procedures. If death, follow your local protocols. Tell the caregiver explicitly that the infant is dead, and then that helps them begin the grief, their response to their loss. Prevention, put them supine. Side sleeping is not recommended. Put them on a firm sleep surface. Avoid soft materials. Don't overbundle. Don't dress them too warmly. Don't share beds with them. That isn't so much an issue of SIDS, but you can roll over on top of them during sleep and suffocate them. Children with special healthcare needs. There are chronic physical, developmental, behavior, and emotional conditions that these children may need healthcare needs at home, maybe ventilators, G-tubes, shunts, all those sort of things. And we're not going to be the experts on that, but we may get called when the child gets really sick and is unstable or critical, and we will just have to, if we're not familiar with the special healthcare need, the device, have the caregiver explain to us, their thoughts on why it's not working, or is what we're seeing in the child have anything to do with that device at all. They may have partial or total airway obstruction with tracheotomy tubes, respiratory difficulties in those that are ventilator dependent, bradycardia, and irregular pulses and compensated shock with those who have pacemakers, fever, nausea, vomiting, headache with those who have CSF shunts, and we may just get called because of a worsening illness with their chronic medical problem. Get a good set of baseline vitals. If they fall outside the range, then you know that they're not tolerating their illness. Look for a medical alert tag. Not sure if the caregiver or parent calls you, I'm not sure you'll need a emergency information form, unless what they're referring to there is if the family has written down all the specifics about the child's illness and their treatment, that you have access to that to take to the hospital. CSF fluid shunts, that's for hydrocephalus, when their normal circulation is interrupted. In that sort of system, there's a shunt placed in the ventricle of the brain because the brain is unable to eliminate cerebrospinal fluid, so it's shunted out of there with this special system. But when cerebrospinal fluid shunts become plugged, they're going to have a buildup of liquid inside their head and have all the classic signs and symptoms of a rise in intracranial pressure: irritability, headache, neck pain, vomiting, bulging fontanelles, seizures, behavioral changes, infection, You want to prevent them from vomiting, prevent them from aspiration, suction their secretions, apply oxygen, assist their breathing, and intubate them if they're not breathing adequately and unresponsive. Check their blood glucose to make sure that's not the cause of this, and treat seizures with your benzodiazepines. And here's a picture of a shunt drainage system. They drain either into the ventricle or into the abdomen. All right, so with that, we've completed this section. I'd like to thank you all for your patience in this lengthy chapter, and we'll see you this weekend in PALS.